So good morning, everyone. We're going to start and hopefully try and finish on time also. So the IC is titled Iatrogenic Complications in Vitreoretina Surgery, a video-based series. This is quickly just a flow of events. So we have 7 presenters. I think we'll have 6.5 or maybe 6 given the time, but we'll see. 5 minutes per presenter, and most will be presenting 2 cases. They could be similar or adverse related, and then that'll be followed by discussion. We've been limited to 55 minutes in total, so that's what's going to happen. Dr. Basavaraj, my dear friend, and my colleague at PGI, he's assistant professor with us. He's going to kickstart this IC for us, and he's going to be talking about two. One is non-operative and the other is an operative complication. Dr. Basavaraj, please.
Thank you, sir. At the outset, good morning, everyone. At the outset, I would like to thank the organizers for giving me this opportunity. So, without wasting much time, I'll directly move on to my case presentation. So, I'm going to talk in my presentation about a post-operative retinal fold. Before moving into the case, we'll have a one basic introduction slide. So, these post-operative retinal folds are classified basically into a tractional, non-tractional, and then hypotony-related chorioretinal fold. So, my topic, I'm going to focus only on the non-tractional variety. Among the non-tractional variety, there is something called inner retinal fold, outer retinal fold, as well as full thickness retinal fold. Among the full thickness retinal fold, again it is classified into two things. One is dry full thickness retinal fold, another one is full thickness retinal fold with subretinal fluid. So this is outer retinal fold, this is inner retinal fold, and this is full thickness retinal fold with subretinal fluid. So in my first case, like a 54-year-old female presented with a poor visual acuity gain following a scleral buckling for a phakic macula of. She underwent a buckling surgery for uh, uh, subtotal RD, phakic subtotal RD, where the break was located, just above, superior nasal quadrant, just anterior to the equator. This patient, we took to the surgery and then we performed a scleral buckling. After seeing the.
But sorry, mic में बोलो. Sorry. Mic में बोलो. Sorry. I'm sorry.
So this patient we took for the surgery and then we performed a scleral buckling. So with the help of 277 in the superior nasal quadrant, and then the drainage retinotomy was done in the inferior temporal quadrant. So intraoperatively we found a little bit hypotony, and then we have injected a air bubble, as well as there was a drainage retinotomy site subretinal bleed complication was noted. So this was the post-operative peak where the retina was settled, but unfortunately there are two full thickness retinal folds were noticed. One is starting from the disc margin and then extending temporal to the fovea. Another one is just above the superior arcade. The corresponding OCT shows full thickness retinal fold with subretinal fluid. So we counsel the patient, and then we have taken for the surgery to resolve this complication. So this is like we waited for another after about 4 weeks, but still patient the full thickness retinal fold didn't resolve on its own. Hence we have taken for the surgery. So in this surgical video, I'm going to show you. So in this, we completed the vitrectomy. After completing the vitrectomy, we just stained the ILM with the help of BBG. And then after removing the BBG, we completed the 360-degree ILM peeling around the fold. So once we completed the ILM peeling, then with the help of 38 gauge Med1 subretinal cannula, we just injected a BSS plus solution. The amount of BSS plus solution is almost like it should be injected in such a way that the full thickness retinal fold should resolve on table only. So there is the most important precaution at this step is we are not supposed to inject the subretinal BSS exactly on the fold. Either it should be above or below where the retina unfolds on its own. So without any much manipulation. After in this video, we can see that step very beautifully. After this, like we just completed the surgery by doing fluid air exchange and then SF6 gas tamponade. So this is the post-operative day peak. So at the time of presentation, the visual acuity was 1/60, and then there was a full thickness retinal fold with a subretinal fluid. In the after 2 months post-operative peak, the retinal folds are completely unfolded, and then the OCT shows a very residual fold. It was much better than the pre-operative. So in similarly in one more case is there, like in that condition there was a dry retinal fold. In this patient underwent PPL, PPV, and then buckling for traumatic RD 2 months back, and then at the time of presentation, he had a visual acuity of 2/60, and there was a full thickness dry retinal fold, which is involving the fovea. Again, we repeated the same step, same surgery was performed, and then after 1 month, the dry retinal fold was completely resolved, and then patient visual acuity was improved to 636. So there are certain predisposing factors for post-operative retinal folds. One is the most important thing is the superior bullous RD, either air or gas tamponade, immediate post-operative heads-up posture, residual SRF, or else incomplete drainage, or else non-drainage techniques. So another one is like scleral buckling with air or gas bubble injection. Last one is giant retinal tear. These are the most important predisposing factors for the post-operative retinal folds. So management. So prevention is always better than cure. So hence the most important step in these conditions is immediate post-operative prone posture, irrespective of the break location, is going to minimize all these uh, retinal folds. So if there is an inner or else outer retinal fold, just we have to observe. If there is a full thickness extramacular folds, again we have to observe. The third thing is like asymptomatic full thickness dry macular folds. Again, nothing has to be like required, just to observation is required. Third thing is if patient is symptomatic with full thickness dry macular fold, then PPV, ILM peel, and then subretinal BSS with gas tamponade, and then followed by prone position is going to help us. If there is last condition where the full thickness tractional macular fold with subretinal fluid is there, then again we have to repeat the procedure to relieve these folds. So in my second case, a 23-year-old female, diminution of vision from last 10 days, which was sudden in onset and painless, and she was diagnosed to have a aplastic anemia and admitted in our medical department for about last 3 weeks, and then she complained like diminution of vision from the last 10 days. So at the time of presentation, her visual acuity was 3/60 in the right eye and 6/12 in the left eye. The fundus examination shows multiple white-centered as well as dot blot hemorrhages, and along with the premacular bleed, especially in the right eye, which is about 2 disc diameter. So this is the enlarged peak where we can see a 2 disc diameter blood which is covering exactly in front of the fovea. So this is the OCT which shows localized hyaloid detachment as well as the subhyaloid blood. So we performed before going into this thing like PPV, we just performed India laser hyalodotomy. I think it was some 4-5 years back where when we started doing India hyalodotomy at our center. We started with the 2 millijoule energy, and then 2 or 4 spots are required. In our center, we have a Apasami as well as the Goldman 3 mirror contact lens, and then 2 or 3 spots is more than enough to do the procedure. So this is the serial picture after the procedure. This is taken after 5 minutes, this is after 10 minutes, and this is 15 minutes, and this is after 20 minutes. In all the pictures, the blood is trickling down into the vitreous cavity. So this is after 3 weeks post-operative field. First one is at the time of presentation where the visual acuity was 3/60. After the procedure, after 3 weeks, the visual acuity is improved to 6/60, and then we noticed a full thickness macular hole with the migration of the blood into the subretinal space. This is a known complication, or whenever we use higher energy, or else we exactly hit the fovea with the help of laser, then these complications are notorious to happen. So we published this case in IJO. So, and then after learning from this mistake, and then we have performed about 9 cases. So where like the
Basaf, we'll come to that. We'll come to that. We'll come to that. So thank you. Sorry, I'm going to try and be as like that. Thank you, Basaf. I'm going to first start the discussion with the second of your cases, which is the YAG hyalodotomy for premacular bleeds in patients who might not be able to undergo surgery, are not willing for surgery, or for whatever the reason might be. Just going to throw it out to Samyak. I'm going to pose this to you. If you were to offer this to somebody, short of vitreous surgery, what would be your case selection? Who would you offer this to? Just any patient with a premacular bleed? What would be your thoughts on this? Any takes, any pointers for this? Coagulopathies, what's your take? Can we get a sorry, एक डिटैचेबल माइक है आपके पास?
Hello. Yeah, thank you, Mohit. Good morning, everyone. So first thing first is most of these patients would have some coagulopathies. So we want the patient to be stable before you take up that patient for surgery. That would be my first criteria. Second, you should be able to validate that this is not spontaneously improving and it is causing a major loss of vision. For example, at times it will be bilateral involvement. So you want to at least mobilize the patient in a way that the vision starts improving. And I think about 660 counting finger vision to 636, I think
would be your indication to manage.
yeah. And on the OCT, you will be serial OCTs. You will be seeing, of course, how the fluid is being resolved, how things are getting.
Fair enough. I think so. Again, Basaf, just one last question regarding this to you, and then we come on to the retinal fold thing. Given that you had one macular hole in one of the cases, and then you went on to do 8, 9 others and did not have any, what would be your 2 or 3 pointers that you would say that if this is the size or extent, or you should do it or not do it?
Sir, like at most, caution is like we have to use minimal possible energy. Like we have to avoid the fovea. Like we should avoid the hitting the fovea. Either we have to consider most dependent part depends on the foveal location, depends on the blood location. It should be reserved for at least a 3 disc diameter, more than 3 disc diameter subhyaloid bleed. The third option is, sir, we have to try in other areas with the patient head posture adjustment. So because of that thing, we can avoid these foveal related complications. The ERM and other complications, it's not there in our hand, but at least this complication we would have prevented if we use a little bit precautions.
So size is the most important factor, you're saying. Anything smaller than within the arcades,
More
and if
than
it's
two
not
disc
high enough,
diameter.
you'd run the risk of that happening. Fair enough, fair enough.
See, the my point is most of these patients are very young, like in their 20s or maybe you can say 15 years old or maybe up to 25 or 30. See, the risk of development of cataract, the risk of developing you can say of detachment in their life, glaucoma also. So putting all these complications, you can say, or to avoid all these complications, I better prefer to just observe only. Whenever any development of ERM or pucker is there, then it's good for me to go and intervene. But conservative management is the, you can say, for the, if you see the long life of the patient, it's not good. These are very, very adults.
Point taken, sir. Absolutely, very well. I think there is no urgency. I think all of us agree on that. It's in the blood's in the premacular space. There is no rush to go in and do anything. But there is a argument to be built if it's bilaterally, macula affecting, and the low HB, the low platelets is not going to get back, is not going to get better in a jiffy. He has aplastic anemia. He has other things. He might have a truncated lifespan, during which you would want to try and get his quality of life better. Or he might get better because of, let's say, he got dengue related or some infection related his platelets are low, and they might be able to get that better in a 4, 5, 6 months time. In that patient, you might want to wait, but if it's bilaterally affected, you might want to try and get his life better there. But absolutely agree, there is no urgency. It's not like blood in the subretinal space. We can observe it. One last point, Simar, and then we're going to move forward.
Baswa, if you were to take home something from this, do you think the location from the fovea would be a factor in choosing when you want to do it and not? Because this was relatively, I think, within 500 microns from the foveal center where you chose to laser.
Similar, the simple thing like fovea is like if you divide the disc into 3 parts, one the upper one third, middle one third, lower one third. The fovea is in the lower one third. it's a common sense. We have to avoid that area. If you want to do a laser hyalotomy in
Do
a,
you think that was a factor in this one in causing the hole?
the factor, if
Or
I
was it just
if
the
I
contraction that
no,
caused the
if
hole?
if I speak frankly, the factor is like I have given this to my fellow, so he was inexperienced, and then he just did it, and then this complication happened. After this, like when we are taking all kind of precautions because of that thing. I have done 9 cases. None of the cases have any complications. Every patient has got 6 by 6, 6 by 9 vision. So I think it's better to like review ourselves.
Is there any distance from the fovea that you would recommend to do
So
this?
at least 1 disc diameter away
One
from
disc
the
diameter.
fovea in all the directions. Wherever you want, you can do, but you have to alter the head position.
Thank you, Basav. With that, I'm going to invite my mentor, Professor Ramandeep Singh, sir, who's professor at the Advanced Eye Center at PGI. Sir is going to be talking to us about jet stream injury and about subretinal silicone oil. Sir, please.
Thank you, Mohit. I'll just play this video. This was as you saw that iatrogenic injuries, when we are in the flow of the, doing some surgeries, sometimes we tend to make these, I won't call them mistakes. They are, you know, kind of the things which teach you lessons actually. So you have to learn from others' mistakes, and and learn from our own mistakes also, so that you don't repeat them in the future. So I was operating this guy. First of all, the green tip fell inside, and sometimes it happens. They go inside, but it's easy to take it out. You can take it out through the same port in the walled, non-walled cannula. That's okay. So I was trying to complete the surgery there. I was trying to peel the ERM in the same case, and once I've done that, then uh, because most of the times with the ERM we know that the ILM comes out, but sometimes we do kind of try to put in some dye there. So this is what I'm going to do, put a dye. But again, in the flow, the dye was given to me, and I shot this dye into the eye. See, the tip was not there, so I didn't realize that, and when it went in with a jerk there. So because there was no green tip, I was using that force, so it went and kind of a blast there, little to my luck, little temporal to the this thing. So again, because it was a macular injury, I didn't have to do much because already the ILM has been peeled. I closed this eye and hoped it will do well. But this thing taught me that always prime the instruments outside, always use new instruments. If you reuse them, these incidents can happen because the green tips can get plugged with the debris there, and they get be pushed into the eye. And this is the patients eventually, if you follow the rules there, or do the basic things and don't mess up things, that they generally are very very forgiving kind of thing, and God takes care of everything. And this is my case about this iatrogenic injury with the ILM. Yeah, whatever you say, Mohit, sir. So, like Mohit said, we will discuss this case later. And there was this case of a subretinal silicone oil. Oil can go inside the eye once you have like a PFCL. If you have not taken care of the traction, like the PFCL can go back. Similarly, the oil can also go back. Now, it was a difficulty in the era when the viscous fluid, the injector or exchanges were not there. Now, since they are there, we don't have to do it manually. We have to do it automatically. So this cartoon shows that how with the vacuum there and using a long, a needle there without the green tip, or you can design your own needle, you can suck out the silicone oil. So there is nothing great about it, but yes, now the tools are available with which we can do, and we can go there, and from the same retinotomy, you can remove this oil with the oil in situ in the vitreous cavity. You can do it, or you can remove the oil and then remove this oil. Whatever you want to do, this can be done. This is the in situ oil is still there, I'm taking out the oil with the VFC extractor, and this is a very, very easy surgery now. And you have to take care about the last bubble so that you don't engage the choroid and don't cause iatrogenic choroidal injury. And this is about managing a subretinal oil with automatic or a controlled viscous fluid this thing. That's it.
Thank you, sir. Thank you. I'm going to. So quickly, sir. Thank you. As I've always said, at least I've personally learned from sir, and I think most of us at PGI have that. Not to shy away from showing things that go wrong in the OR, even in the most experienced of hands, because the idea is to learn from what you're doing. So coming to the discussion of the second case, subretinal silicone oil, I'm just going to make 2 points, pose one question, and then go on to the next case, and then maybe we can have some discussion later on. So unlike PFCL, going underneath the retina, PFCL, generally you tend to get smaller amounts of PFCL, and it could be multiple. There could be a lot of bubbles, fish egging, you could get a lot of PFCL, but you would notice that during surgery. It'll be a jet stream which will go in, which is a decidedly rarer phenomenon. Oil under the retina is more difficult to get as compared to PFCL, but if and when it does go, it generally will go in the post-operative period. Once traction, because I'd like to believe most people, once they've done vitrectomy, to the best of their ability, they have removed as much traction as they possibly can at that time, and at that time the oil in the vitreous cavity was fine. Later on, there are membranes there, you couldn't remove them, or for whatever reason PVR happened later on, and that caused either a pre-existing break to open up, or something like a heavy retinopexy, and that to open up, and that cause oil to go in. So once you get oil under the retina, in contrast to PFC under the retina, oil will very seldom be a small bubble or multiple small bubbles everywhere, because of the property of the oil. It'll actually stick together. So it'll be a large bubble, and depending on how much traction you have, you can get a lot of oil. You generally get a lot of oil under the retina. And the general dictum people tend to believe and follow is oil under the retina equals retinectomy always. I think Dr. Raman just showed not in every case. You can, depending on where your break is and how much traction there is, you can get away with without doing a retinectomy, even with oil under the retina. And one of the good ways of getting it, and especially in long myopic or bigger eyes, is if you use a 25 gauge flute with the soft tip removed, and jack up the extrusion absolutely to the maximum. You can even get out 5,000 centistroke silicone oil from under the retina. We have done that for a couple of patients who've actually had oil put elsewhere and have had 5,000 centistroke oil under the retina. So even that is possible, because getting your VFC all the way down into the subretinal into the subretinal space is near impossible because of the length of the eye. So that is one good way. You can also attach the same cannula to the VFC tubing and use that to extract directly from the subretinal space, because access becomes an issue. I'm not going to pose any more questions. Ramanuj, please.
I had one question to sir. Sir, if the location of the subretinal oil is away from the primary break, so would you like to milk it with the PFCL, or will you like to do a retinotomy over the silicone oil and try to aspirate from that place?
I think Raman sir will take that. And Ramanuj, after that, I'll request you to also come for your talk, please.
You can milk it with your diamond dusted scraper. You can milk it towards it, not it goes there easily. But if it is not going there, you can make a retinotomy over it and you can take it out. Depending on the make it superiorly, it is better. But you can always milk it through that retinotomy. It can go there. Once it's held with the suction, it will not go away. Yeah.
Thank you.
Yeah. I now invite Dr. Ramanuj, my dear friend and colleague from PGI, who's doing excellent work up in the hills in the north. He's assistant professor at AIMS Rishikesh, and he's going to be talking about microcannula follies. Dr. Ramanuj, please. I just have to make one more point, that you can also get a lot of emulsified silicone oil under the retina, particularly in cavitary optic disc anomalies, with apparently no PVR, nothing, because of the disc and the peridisc area being anomalous. So morning glories, optic disc colobomas, regular pits for whatever reason. So everybody knows it can migrate into the orbit, into the brain. It can also migrate under the retina and can be emulsified. So that is something that one needs to be particularly clear of. And once you get emulsified oil under the retina, well, then that's a different kettle of fish. Removing that, tackling that is, because then it becomes like PFCL, multiple bubbles. You can't get it out the way you do, like this, and you can't keep doing lavages under the retina. So that is possible, although extremely rare, but word of caution in cavitary optic disc anomalies. Dr. Ramanuj, please.
Thinking about iatrogenic complications in vitreoretinal surgery, some cases of intraoperative choroidal detachment during small gauge vitrectomy. So intraoperative choroidal detachment during small gauge PPV is uncommon, but one of the dreaded complications. So I will show two videos on infusion cannula associated choroidal detachment. The first one is due to acute ocular hypertony, and the second one is due to retraction of infusion cannula. So the first patient was a 42-year male, no comorbidities. He was operated for left eye cataract surgery elsewhere 2 years back and presented with decentration of PCIOL following a recent blunt trauma. So I planned for PPV plus IOL refixation or explantation plus minus SFIL. So again, the case was started by my fellow. So at the beginning, peritomy was done probably because they did not feel that the support is enough. So SFIL was planned. So after gentle cautery, standard 23 gauge ports were made 3.5 mm from the limbus, and infusion cannula was checked, visualized, and then started. So incision is given with keratome and the IOL was explanted and suture was done at the main port. Now we saw some latticed patches. So those lattice patches were taken care of after core vitrectomy. Laser photocoagulation was done around those lattice patches. So up to this stage, this was all going fine. This was sutured, and suddenly I noticed that superiorly this cannula was leaky, so probably the valve is not working. So I used some scleral plug, and then I made 1.5 mm from the limbus. I used a 25 gauge needle. I introduced a needle for SFIL, but probably the patient also had iridodialysis at this location, and there was also hyphema. You can note there is presence of hyphema at this stage. And suddenly I felt there is hypotony and loose blood. So immediately I checked and I noticed that the infusion bottle has finished. So immediately there was another line. So AC maintainer, I introduced AC maintainer through superior port. But due to acute hypotony already that happened during the finishing of the infusion line, you can see the amount of the choroidal detachment. So as we had to defer the SFIL for this setting, we closed it after partial fluid air exchange and sutured the scleral ports. Fortunately, the patient did recover well with conservative management with oral steroids, topical steroid, and cycloplegics, and the ultimate visual acuity regained was 20/30. So second case was a 45-year female hypertensive. She had sudden decreased vision in left eye for 10 days, and it was a case of ruptured retinal artery, retinal macroaneurysm, and you can see the subretinal bleed. So after core vitrectomy was done, suddenly you can see at the inferotemporal, just beneath the infusion cannula, you can see there is presence of choroidal detachment. So further sequence of surgery will depend how much is the detachment and what is the indication of surgery. So most of the time, if it is limited, you can go on. Now you can see the infusion cannula has been retracted. It is off from the inferotemporal the inferotemporal cannula, and again it was reintroduced, visually inspected, and then restarted. But however, as it was in the inferotemporal quadrant and there was choroidal detachment, so with increase in the amount of the choroidal mount, we can see that the choroidal detachment has further increased from the previous episode. So we again took out from the inferotemporal site and reintroduced it to a safer area so that where there was no choroidal detachment. So ultimately the surgery could be finished because this was mostly limited to the posterior pole, and we did not require any kind of peripheral dissection or this thing. So how to prevent this infusion cannula related follies? So infusion cannula insertion with trocar at a steeper angle. So if you are introducing at more acute angle, then there will be more intrascleral length of the infusion cannula and less vitreous strength, so that we have more chance of retraction. So always it is good to visually confirm the position of the infusion cannula after inserting in the vitreous cavity. It is good to secure the infusion tubing with a surgical drape to keep the cannula at 90 degrees rather than keeping horizontal, to alert the surgical assistant against accidental retraction, which mostly happens during scleral depression. And the surgeon also needs to periodically recheck the infusion cannula intraoperatively, and particularly before doing gas or silicone oil infusion, we must reconfirm the cannula position. So early intraoperative detection or awareness that the choroidal detachment has happened is crucial. We need to avoid acute ocular hypotony. If there is any open incision, we need to suture it immediately. Need to be vigilant about intraoperative partial or complete retraction of infusion cannula. And it may need to be resecured at another safe place if CD develops. Once CD develops, decision need to be taken to continue or defer surgery to a later setting. Early awareness and timely intervention are key to management in such cases. Thank you.
Thank you, Ramanuj. Great cases. I'm going to request Simar to be ready with this, and then we're going to have the discussion. So just, regarding infusion cannula related, issues, I think he showed two cases in which intraoperative choroidal detachments happened. Both of them were serious. They were recognized in time. The idea is to recognize in time and to stop, because once they keep increasing, although it's a closed system with vitrectomy, once they keep increasing, there is increased pull on the long posterior ciliary arteries, and there will come a point when those arteries will give way, and then they convert from serous to hemorrhagic, and then you get the complete loss of glow, 360-degree mounds. I think one important point to differentiate between whether you are getting hypotony-related globe collapse, which you can get because of infusion and outflow mismatch, versus just a localized infusion cannula related issue, related choroidal detachment, is that that the hypotony in general, infusion outflow mismatch, there'll be 360-degree, almost like a globe collapse, which all of us who have done vitreous surgery understand. There'll be like a caving in of the of the walls of the eye, and that tells you that either your infusion's too low, or it's kinked, or the cannula is partly blocked, or it wasn't checked before inserting, or your vacuum is just through the roof. So there's an infusion outflow mismatch, because there'll be a global issue going on. Whereas if it's an infusion cannula later, I think sight is very important. Both these patients, you saw that it happened in the quadrant of the infusion cannula. So there was localized choroidal detachment in the inferotemporal quadrant where you have the infusion cannula. It can either be partly out, as was in the second case, or be inside, but with the infusion line actually being running dry and you not knowing. I think one important point to look at is, like as he rightly did in the first patient, if the eye is open because it was a bigger limbal wound since he was planning SFIOL, I think at that point in time it's prudent to shut shop, suture the eye, and then come back to fight another day. Whether you want to leave the patient on air or fluid is your call. But if it's a closed system and it's a cannula related issue, as was in the second case, I think the right way to go is that, since the cannula is already in the suprachoroidal space where the fluid is, it's already misdirected. You do not need to take out both the infusion cannula and the infusion cannula with the just the infusion line needs to be removed, not the cannula, because the cannula is exactly where you want it to be to drain that fluid out. The infusion line needs to be shifted to a superior cannula, checked, the globe is being formed, and then if it's a valved cannula, you vent it, all of the suprachoroidal infusion will drain out, because it was a one-time event that you noticed and you took care of it. So you do not need to remove that cannula from the suprachoroidal space. Although if you have done that, you can always do that, remove it, it will still act as a drainage site, it will still drain out, but then you'll need to make a separate separate entry. So all is not lost if the globe is not open. If there's no limbal wound, if it's not aphakic, you can continue with surgery. The idea is to identify it, and if you're in doubt, or if you're not knowing, or if these are too technical for you, please shut shop and come back another day to fight and manage that case. There's no point going on to hemorrhagic choroidal detachment, because that then becomes a very different kettle of fish.
I,
One question more.
Yeah, sure.
In most of the cases where Ramanu showed, and it happens on most of the times, that the media is clear enough for us to understand that there is a choroidal detachment happening. But in cases of endophthalmitis, or where the media, or if you have misplaced the cannula, or for some reason it is not working, you don't understand till you actually clear some of the media. So I think if you're not seeing the cannula, don't put it on. If you can secure one port, infuse, and then go step by step, I think that's more.
Agreed. So if you're not seeing the cannula, can we have the slides there, please? I invite Simmer to give us. Someone, can we have your comment later, please? I'm sorry, we're running short of time. Simmer, करेगा? आप कर रहे हो? I'm going to invite Simmer. I'm just going to say, so one is you're not able to visualize the cannula from the get-go. That is a different kettle of fish. One is you're doing surgery and something happens intra-op. We're generally talking about that, because otherwise, fair enough. If you can't visualize it, then it's a different kettle of fish. Then don't start surgery. Dr. Simmer, please.
Thank you so much, sir, for having me here. So actually, I'm going to skip the first case in the interest of time. I'm going to come because the other case also has two eyes. So in pediatric retinal surgery, especially in ROP surgery, breaks are a big impediment. So I'll just talk about that in one case that it happened and how we went about it. So this was an 8-week-old male child presented late for screening, presented with stage 4A, both eyes laser done initially. This was the picture 3 weeks after laser. Initially, the child was unfit for general anesthesia due to lower respiratory tract infection. So about 3 weeks later, he was ready for surgery, and this was the pre-op picture when we were taking him up. So we planned an immediate sequential bilateral lens-sparing vitrectomy and the left eye first. So this is the left eye video that I'm going to show first. So I prefer to do the eye which I feel has a better prognosis first, because these children tend to decompensate sometime under anesthesia also. So you need to get away with the better eye, giving him better vision first. So this is the stop and slide technique that we have described, because the retina is quite lifted to prevent directly hitting your trocars into the lifted retina. So you can see how lifted the retina is just behind the crystalline lens. And we started the vitrectomy trying to dissect the connections between the lifted ridge and the crystalline lens. And if just notice my cutter port position here and what happened. So that you can see what happened was a lens touch, because my cutter was facing directly towards the crystalline lens. Yeah, I'll just show you in slow motion what happened. So actually the machine was also malfunctioning at this point of time. So this was the lens touch over here. We decided to continue with the vitrectomy and not do a lensectomy, since the touch was outside the visual axis and I could visualize what I wanted to do. So again, the machine was kind of malfunctioning. Only the suction was cutting, the cutting was not coming. Again, pulling on the retina, more of vacuum rather than that. Changed the cutter, tested it outside, reprimed it. Again, it worked for some time, stopped after that. So this happened multiple times, and ultimately we replaced the machine over there with the second machine in our OR, and that was actually, again you can see the same thing happening, only just the vacuum was coming in the cutting mode. This time change the cutter, again the same thing repeated. So ultimately changed the machine and then completed the surgery, dissected all the dissection planes. Then came on to the other eye. We thought, okay, the better eye, we had a complication, let's hope the other eye goes well. Again, you can see this is more contracted retina together and more lifted towards the crystalline lens. A little more careful about the cutter position this time. Again, dissecting the plane between the lifted retina and the crystalline lens. So that went on well. You keep your cutter position kind of tilted at 90 degrees to dissect that, and then dissecting between the ridge and the periphery. And after that, I went on to the posterior pole to debulk the vitreous over there, and then just this happened. So it was in a flash of a second. I'm going to show you in slow motion what happened over there. So again, I think again to do with the cutter port position, it was pointing towards the retina. And just in that flash, that retina comes up and you can see a break that has been formed over there. So the whole retina becomes lax once you dissect it out from the, release the anterior posterior traction, and it kind of becomes like a kind of a fluttering retina. We couldn't do much at this point of time because that break was right at the edge of the lifted retina where the traction planes were. So we decided to close for now, do a fluid air exchange, came out of the eye. To our surprise, this is about 18 days later, once the air had gone away. The retina was completely settled. There was just this kind of hemorrhage over there where the break had occurred. And this eye was actually doing very well. And the other eye, the retina had settled, but obviously had developed a cataract. And under 6 weeks later, the child underwent cataract surgery in this eye and is now doing well in both the eyes. So just some points to ponder. I'll just come on to case 2. So important to consider the position of your cutter tip once you are inside. Once you have released the anterior posterior traction, the retina becomes lax. So that point you need to take care of once you are doing the vitrectomy very close to the posterior pole. Lens touch, I would want your opinion. What would the audience think? Primary lensectomy versus a secondary cataract surgery, be it pediatric, be it adults. And retinal breaks in ROP, is the natural course same as adults, or does the formed vitreous and lack of posterior vitreous detachment work in our favor in that case? Thank you so much.
Thank you, Simar, and appreciate for finishing in time. We're running short. Just one quick question. Once the retina settled, I think you had a great outcome. And I think if it's for all of us people who do not do ROP, and the general thing is कि अगर break हो जाए तो वो आँख तो चली गई. And for the most part, that might be true, but not for every patient. That is one.
Actually, the traditional teaching is that way, sir, but my experience has not been the same, especially in stage 4 cases. And you don't need to be too aggressive once a break happens going around, because you're never going to get the hyaloid out.
Yes.
It's good to leave that hyaloid back there. Maybe if your FAX settles it, do some laser, but don't fiddle it with it too much. If you reduce the vitreous too much, then the fluid is going to go in for it.
Would you do laser? Because I think I might maybe miss that. Once the retina was attached, you had a favorable outcome. You could see the break. Would you do laser posterior to it, or would you think
At
that
this point, after the retina has settled?
No. So after one of the photos that you showed, when you could see the break along that, just posterior to that remnant fibrosis, which was extramacular, would you want to augment some more laser or no?
I think the laser was adequate. It was just at this edge of zone 1. I wouldn't want to come more inside.
Fair enough, fair enough. And I think one more point, I think there is there are also some cases reported by the SN group about macular holes forming in these, in which they've actually been able to salvage not just the eyes, with attached retina, but with some kind of functional vision. So I think the one good take home is that if you get a break in ROP surgery, yes, you do not want a break. We don't want to go out of this hall thinking break ho jaye, koi baat nahi. You do not want a break, but all is not lost, as is generally said. Ki break ho jaye to jane do. Jane mat do. You try and close it, and there is, depending on how bad or not bad the case is, it could still end up with a favorable outcome. Thank you, Simar. Question from you, Aishi.
And don't chase the break, don't remove the hyaloid, don't drain through it, leave it.
Absolutely. Everything that you would do in an adult is not to be done here.
Yes.
So thank you, sir. With that, I'm going to call, thank you, Simar, and Dr. Ayushi, my dear friend. She's going to be talking to us on 2 cases of post-diabetic TRD related, 3 cases maybe of diabetic TRD related challenges. And let's see how they were managed. We're running short of time. I'm going to omit my cases. We'll just have Samyak's cases after this so that we can do justice to discussions to both of them, and then we'll be able to finish on time.
Yeah, morning everyone. So I'll quickly take you to 2-3 cases. So this is case 1, 52-year-old male, diabetic for 6 years, on oral hypoglycemics, hypertension 4 years, both eye perception of light. This is the B scan. Right eye has minimal VH, left eye very dense layered VH. Over the next 45 days, I planned the right eye mature cataract surgery. He was ambulatory with 612, initiated PRP. The left eye, the next 3 weeks later, we did diabetic with pre-surgical Avastin. Nothing out of the ordinary, uneventful surgery, very dense old VH, carefully cleared in layers. It was a treatment-naive retina, so around 2,500 spots of endolaser was done. Eye was closed in saline because the other eye after PRP had bled, so just to give him that ambulatory vision. This is POD1. He improves to 618. Anterior segment is absolutely quiet, but the fundus is showing dense transvitreal fibrin strands. Retina seems attached. OCT shows macular detachment. At this point, I started on topical steroids early, did not give any systemic steroids, sugars were high, and routine post-operative antibiotics were continued, oral. None of the patients on the same day had any sort of inflammation in their eye. This is POD2. Again, vision is dropping to 660, but fibrin bands are somehow retracting, but the detachment at the macula was worsening. He wanted to go home, so I sent him off with some Visalon under monitoring of his sugars and 1 hourly steroids. Comes back on POD4, vision is again worsened, but bands are less. But then OCT shows a massive detachment, query serious, not sure tractional, because these fibrin strands were attached on the retina, at the macula, in the periphery, and I could see that the retina was lifted at those areas. So I immediately planned for fibrin removal with oil injection. He was practically monocular at this time. This is POD1 post-SOI. He's improving to 624 over the next 2-3 weeks, uneventful SOR, and he's doing fine. This is the second case, 63-year-old female, DM 20 years on insulin and hypoglycemics, CKD on dialysis for thrice weekly. Right eye is lost to NVG, left eye is hand movement, undergoes a 25 gauge PP with endolaser under proper anesthetic care. Eye is closed in saline and sclerotomies were sutured. Vision post-op is hand movements. AC shows cells, but there's no hypopyon and there's fibrin on the PCIOL. Posterior segment, there is CDs, exudative RD, and you can see on the corresponding OCT, there is subretinal fibrin. Suspected to have toxic posterior segment syndrome. Half-hourly topical antibiotic steroids were continued, and she was sent for dialysis the next day. POD10, she's not getting better. Vision is still CF, exudative RD, fibrin is persisting. So 20 mg of PST is given, and topical steroids are continued. This is at POD 1 month. Vision is 660. AC is quiet. There's dyspallor, and all the signs of inflammation have resolved. I think I have time. I'll quickly go on to another case. This is a case of monocular. Okay, this is another case where she underwent diabetic WIT. It was a treatment-naive retina. That is POD1 here with 360-degree CDs. She was managed only on topical steroids, and she kind of resolved. So these are the 3 cases of the transvitreal fibrinoid reaction you can say over the spectrum. We can discuss this.
Thank you. Thank you, Aishi. I'm going to pose the question to you, and you can be there. I'm going to pose it. Thank you.
To me?
So you showed 3 cases. I think the idea was that all of them were complex diabetics. One was a tractional retinal detachments. All 3 were monoocular. 2 were premacular bleeds. And patients were systemically unstable, sick, had nephropathy. 2 of them were on renal dialysis, and all of them on post-op day 1 had fibrin in the AC, fibrin in the vitreous. One of the patients had fibrin underneath the retina. 2 of the patients on the ultra-wide field photo showed peripheral choroidal detachments and exudative detachment in the macula. Now, one was managed with re-surgery with oil. One was managed just with topicals, watchful observation, and getting the patient's systemic status. And of course, they were already on renal dialysis, but ensuring it was done because surgery is also a stressor. The third was, managed with topicals. And once the response wasn't as prompt as you would want it, it was augmented with a posterior subtenon injection, and that got it better. Now that you, have shown us the spectrum, if you were to revisit these, what would be your take? If you get this on post-op day 1, how would you say, what is the best way to manage these?
I think the first case, I did not think of PST. He was monocular, and I think when I was operating, the vitreous hemorrhage was very, very dense. The yellow chicken fat kind of a thing. And of course, there was a peripheral skirt where you cannot do base shaving. And of course, there was thorough laser. So I was thinking more on those lines, and I didn't want to give a depot of steroid in the posterior subtenon space. So probably next time I'll think of a PST in such cases, and probably see with that rather than just going and operating on the 5th day. So that's my understanding from both your cases that I'll try that.
Well, fair enough. Anybody else has to add anything to that?
Are you using anything from the formalin chamber in your OT? Are you using anything from the formalin chamber in your OT?
No.
First, okay.
No, we don't have formalin.
Second thing is that what I have I have observed that whenever we leave BSS or any simple fluid, then we have these kind of cases. If we are using the FAE or any tamponade, then most of the time we don't see or never we see. Somehow it has linked with that fluid. The BSS we leave, the simple fluid we leave, we have these kind of things.
My only thing is, we do a lot of these cases. We do leave saline, and I've never had this. I've just been two
No, no, no.
cases,
These are
and
rare.
sometimes I've seen them at the interface of the air and the inferior
Interface.
saline. Even there, I've seen at that interface there was
this
a
is
web.
this is my point, that
Yes.
whenever we leave, see, it always happens with the fluid only. It never happens with the tamponade.
Yeah.
Or maybe we don't see it with the air in the eye. Yeah. Raman sir's point.
I think,
Point taken, sir.
I've seen a lot of these cases with Professor Mohit Gupta sir also there, but we generally saw in bad patients, nephropathy patient, it happens. But what works was, sir used to say, was subconscious DEXA used to work. Nowadays we don't give it. I think
Absolutely, sir. And just to round off the discussion, and I think on post-op day one, a diabetic vitrectomy, a complex one at that, membranes have been removed, or you have done a lot of premacular, your hyaloid removal, blood removal. You get fluid in the macula. You see fluid. I think three things come to mind. One is a regma, which you did not notice, and that happened. Although you'd be struggling to come up with a case from your recollection, where on post-op day one, even if you had a break which you did not detect, you have a RD in a diabetic case. But that is one. The second is there is low pressure. Either it was not sutured, that caused the choroidals and all of that. The third is endophthalmitis, because post vitrectomy presentation of endophthalmitis would be different from let's say post cataract. The fourth one, which is unique to these systemically unstable, rather sick patients, and as Raman sir pointed out rightly, patients with chronic renal failure on renal dialysis, because their body has a lot of fluid overload, it can't excrete a lot of stuff. They are generally on renal dialysis. Coupled with that, surgery is a added stressor for them that puts the whole system, gives the whole system sends the whole system for a toss. And the idea is, if they're on twice weekly or thrice weekly dialysis, to have a dialogue beforehand. This is what I've been doing, that they have to have their next schedule of the dialysis a day after the surgery, because that ensures that a lot of the fluid which is retained in the body goes out. The systemic parameters get better, because no matter how good they are, once they undergo surgery, and mind you, eye surgery might feel like kya ho gaya, body mein kya fark padega, it's a stressor. Patient has received a local block, might be under general anesthesia. The whole body, the system of these already fragile patients goes for a kind of water retention, catecholamine release phenomenon. So you have to ensure they get renal dialysis. The next day, most of them, if not all, will resolve without having to resort to surgery. Topical steroids and oblique or periocular steroids is the way to go. But of course, one has to rule out hypotony, because if that's the cause, then there is a separate kettle of fish. So intraocular pressures are very important to be looked at. And endophthalmitis is something post PPV, thankfully rare, but you have to ensure that it doesn't come back to bite you. So if there is hypopion is something that will never be there in these patients, even if there's a lot of fibrin. So then your antennas have to be up. But the idea is, the toxic posterior segment syndrome in sick diabetics with CKD, please manage closely, conservatively, and most, if not all, will do fine conservatively, but topicals may be augmented with posterior subtenon. With that, I'm going to invite my dear friend Dr. Samyak. He's going to be talking about the last case. He's actually a consultant at Mahim in Mumbai, and he's going to be talking to us about two cases. Samyak, please.
Thank you, Mohit. Thank you for the opportunity. Yes, thank you, Mohit. I'm going to talk about globe perforation following the peribulbar block and the posterior subtenon injections. So they are the most commonly performed ophthalmic procedure, and inadvertent needle injuries, though they are rare but are devastating procedures. In a large series, the incidence is really very small, close to 0.002%, or 15 out of about 6 lakh patients. So what are the risk factors? One is the axial length. more than 26 millimeters, and the risk of injury, goes up in 1 in 140 cases, whether with or without staphyloma. In a staphylomatous shape, because there is unpredictability, there are chances of 50% perforations which occur at the junction of the staphylomatous and the non-staphylomatous area. And of course, multiple injections, poor patient cooperation, previous history of scleral buckling, in ophthalmos, well, there is a debate whether right versus left, blunt needles versus sharp needles, and ophthalmologist giving the block versus non-ophthalmologist. So what can exactly happen? You can have retinal breaks, vitreous hemorrhage, rhegmatogenous retinal detachment, retinal incarcerations, endophthalmitis, choroidal hemorrhage, and globe exposures. So let me go quickly through the video. This is a video courtesy Dr. Simmer. My video didn't get recorded. So this is a 60-year-old woman with low vision since cataract surgery and was about a month post the cataract. This was a 25 gauge pars plana vitrectomy, and you can see that the vitreous hemorrhage has almost turned gray now. And as we go through the surgery, do the core vitrectomy, clear the media. Sorry. Okay, I have to go through the video again. Sorry, Mohit. So once the hemorrhage is cleared, we see that there is a superior retinal break there. There is incarceration. There's probably a point of perforation. Yeah, you can see superiorly that there's a retinal hemorrhage there. And once we dissect that small part of hyaloid there, there's the small area of vitreous incarceration. Fortunately, there is no retinal detachment there. And in most of these cases, there will not be a retinal detachment because once the needle perforates there will be retinochoroidal adhesion, and that's a good adhesion, in fact. So once that is done, there will be laser applied to that area and fluid exchange. So 50% of breaks will go undetected. And so how to recognize? So 50%, there will be severe pain of the patient, so never disregard. So it will be tense IOP, high IOP, that should cause the alarm. You can see sometimes the eyeball enlarging, there will be a loud popping sound at times, floaters, blurring of vision, hypotony, loss of red reflex, dilated pupil, all these are the factors. And what to do? So in a clear media, you can assess the IOP, do a paracentesis to prevent a CRAO. Laser to the retinal break can be done immediately. You can postpone the cataract surgery. However, they still debate if the glow is fine, you can go ahead with the cataract surgery. And if there is hypotony, vitreous hemorrhage and no view of the fundus, we can immediately refer to the VR surgeon and do a B scan and plan a retinal detachment surgery. If there is only a vitreous hemorrhage but no RD, we can await for the clearing of the vitreous hemorrhage. So what are the recommendations? That, well, always make sure that the patient looks in the primary gaze. The needle, whether it is 25 gauge needle, push the eye superiorly with the index finger, wiggle the globe so that you watch for the simultaneous movement of the globe, aspirate slightly so that you are not inadvertently having an intravascular entry. Do not force, do not push, and slowly inject. But second injection you should be aware of. So what is the prognosis? Depends on the site of entry and whether there's an exit or not. If there's no detachment at presentations, 90% of them will not have detachment, and 50 to 80% will have good vision, close to 20-50. And if there is a if there is a detachment at presentation, which is in about 67% of the cases, the anatomic success is less. It may be there, but the vision remains poor. PVR can be there even at presentation, and PVR can cause redetachments as well. Quickly, okay,
Thank you.
thank you. In interest of time, I think we'll let go.
Thank you, Samik. We're going to truncate. We're already 5 minutes over schedule, so no discussion for this. I thank the audience and all my co-participants for this. We can maybe discuss PST Canada over a cup of coffee. Thank you, everybody.